Educational session on what's the link? A discussion on the link between breast and ovarian cancer. I'd like to first thank my pastor for being here today, the Reverend Cara Rockhill, and for allowing this beautiful space. So if one of you fall asleep, then I'll know it's because of the waterfront. And I am so thankful that the rain stopped. I mean, I was not looking forward to today because I felt that it was going to wash away some of our attendance. And while it did affect some, I want to welcome you for braving the storm and being here. We have a wonderful program in store. And because of the challenges we had in the beginning, I apologize and I thank everyone, particularly our guests on Zoom, for being patient while we work through our technical issues. I also want to say that, as Reverend Carr said earlier, I'm Thelma D. Jones. And we all know that we were expecting to have the wonderful Jacqueline Beal to MC. However, I learned early this morning that Jacqueline had been exposed to COVID. And to err on the side of caution and in keeping with our church's policy, we decided that it may be better if I were to MC on her behalf. So I do hope Jackie is doing okay and that she's watching us. We'll say hi, Jackie, just in case she's up watching. The Thelma D. Jones Breast Cancer Fund was created as a support in April 2010, modeled after a support group at the World Bank group. Some of you may know that I retired from the World Bank after more than 33 years. And in 2012, our support group evolved into a full-fledged organization. And since then, we have had, this year, we decided to bring the event home. One of the things that the Thelma D. Jones Breast Cancer Fund has featured during its support group meetings has been the connection between family history. And almost every December for the past 7 years, our theme has been children of breast cancer, children whose parents have breast cancer, whether living or deceased. And during those discussions, we talked about many of the things that we will talk about today, the many distinguished features that we have on our agenda. I could share more about the Thelma D. Jones Breast Cancer Fund, but let me just tell you our mission is to improve the overall health and well-being of women, men, and young girls, because as we know, younger people are getting breast cancer and other forms of cancer at an earlier stage. And not only are women or young girls getting breast cancer at an earlier stage, the breast cancer is more aggressive and they are being diagnosed at a later stage. And we'll hear more about that under the various topics that we will discuss. And so with that, I would like to start with our opening remarks and to also say a special welcome to all of our guest speakers. And we have a range of distinguished speakers as far away as Portland, Oregon, to here in Southwest. So I'd like for you to sit back and relax as we welcome all of our wonderful speakers. I might add again, we had a terrible storm here in the Washington, D.C. area. Actually, I think they refer to the storm in parts of the DMV as a tornado. So with that, I hope it will not have any more challenges, or that we will have any more challenges with our technology. But we all know how technology is a wonderful tool, but it also will embarrass you at the right time. So with that in mind, I'd like to welcome LaShawna Thomas Walker, who is the newsletter editor and board of director of the Thelma D. Jones Breast Cancer Fund. LaShawna, who has come all the way from Atlanta, Georgia. Welcome, LaShawna.
Hi, good morning. Thank you for being here. For those of you who are on Zoom, you haven't seen me running around frantically. Those of you in person, you have. But anyways, thank you all for being here. Like Ms. Thelma said, I'm Sean Thomas Walker. I am the newsletter editor for the Thelma D. Jones Breast Cancer Fund. I'm also on the board of directors, which I'm really happy about. What she touched on briefly, that I do want to say that this is, last year we did this, it was a party organization that specializes in ovarian cancer that affects Black women. That their home cities are like Georgia, where I currently live. But Ms. Thelma and I met while I was here in grad school at DC walking my dog. And as you all know, if Ms. Thelma meets you, she'll never let you forget that she knows you. And she will call in those favors every single time she has an opportunity. As most of us in this room have been called in for that favor. I want to thank all the speakers who are here today. As this being our second year, we are still working out what we want this to look like in the future. Yes, it's a discussion on breast cancer and ovarian cancer, but as we move forward in the future, we want other people to understand, well, everyone to understand that breast cancer is not only linked to ovarian cancer, but other cancers. And if we can, every cancer has its support, has its awareness, but if we can come together at some point during the year or throughout our lives, so we can recognize that it's impacting everyone, no matter your age, your gender, your ethnicity. Cancer is one thing that does not discriminate, which everything else would not discriminate, but cancer is one of those things that does not discriminate. And we want to make sure that we are providing awareness, but most importantly, we're providing resources and support. If there's anything that you all leave here with today, hopefully it's the fact that there's someone else here that cares about you. And there's not just someone else, but there's experts that care about you enough to keep on pushing and doing the work. Thank you all for being here. I wish I had more to say, but without further ado, I'm going to pass it back on to Thelma D. Jones so she can introduce our guest speaker.
Thank you so much, LaShawna, and thank you for all that you're doing in a dedicated and committed way to help ensure that we honor and live out our mission, which is especially around making sure that no one travels their journey alone, and more importantly, emphasizing early detection saves lives and creates better outcomes. So we hope that you will walk away with something from all of the speakers. But if you don't, the one thing that is important to remember that all of the speakers may touch on is the fact that early detection saves lives and creates better outcomes. With that, I'd like to introduce our guest speaker. And because we had started quite late, I apologize for not um, going into details about our distinguished speaker's background. So rather than sharing their bios, we will share that later next week so that you will have a greater sense who actually spoke. And I welcome the speakers to mention part of their background to help put their presentation in context. The next speaker is a young lady that it's important that we know that even though she lives all the way on the other side of the world in Portland, Oregon, she has a connection to Washington, D.C. She's a graduate or alum of Howard University. So we say, HU.
You know.
All right. So with that, I welcome our guest speaker, Bethany Johnson, MD, FASC, who is the Senior Medical Director, Legacy Cancer Institute. And I might add that we met at a conference in March hosted by the National Consortium of Breast Centers in all the places in the world. We met at the casino in Las Vegas. Well, you know, somebody has to be there. And after being there for 4 days, I realized, for 5 days, I realized the last night I had not been down to gamble. And I thought, oh, I felt under pressure. You gotta go down and gamble because that's gonna be the first thing that people ask you is, did you win any money? So without further ado, Valerie Johnson from Legacy Cancer Institute in Portland, Oregon.
Good morning, and thank you for the invitation to be there. One of these days, maybe we can do it in person, because I love DC, like you said, HU, you know. Let me share my screen. Thank you for the invitation to be here today. And I was asked to talk about the link between breast and ovarian cancer, but there's a link between breast, ovarian, prostate, and pancreatic cancer. So I'm going to tie all of that in together. Okay, got it. So I want to start with the end. So I want to start with the take-home messages. At the end, I want you to remember that breast cancer can be related to several other cancers, that BRCA1 and BRCA2, otherwise known as BRCA1 and BRCA2, can be inherited and are associated with breast and ovarian cancer. And this is particularly prevalent in African American families. Prostate cancer in men can be a signal of risk for breast and ovarian cancer in their sisters and daughters. Pancreatic cancer can also be associated with breast and ovarian cancer. So if there's family history of that, that should also be a signal. And remember, as Thelma already said, appropriate screening leads to early detection and more cures. So I want to start out with why we focus on this so much. And African American women and breast cancer is truly an opportunity for improvement. And that's the same with ovarian cancer and other cancers, both prostate and pancreatic cancer. We can improve the outcomes for African Americans. Right now, our mortality is higher. And part of that reason is because of something called triple negative breast cancer. And I'm sure this crowd is probably quite aware of that. African Americans in particular have a higher incidence of triple negative breast cancer, which is an aggressive form of breast cancer, more difficult to treat, and the outcomes are not as good. And there's definitely a tie-in with heredity because we see that same pattern in West Africa. So as you can see on the slide, the highest incidences of triple negative breast cancer occur in Senegal, Mali, Nigeria. And those are all places that by history, the slave trade brought Africans from that coast of Africa into the Caribbean and United States. And so we see those same patterns. But as we talk a lot about triple negative breast cancer, I also want to sort of depart a little bit from that, just to say that there's some other areas where Black women have more aggressive forms of breast cancer, and to raise awareness, particularly in the treatment of estrogen receptor positive breast cancer. So when we're treating that type of breast cancer, there are testing that we can use to help us understand whether women should have chemotherapy added to estrogen blocking therapies. And one of the most commonly used tests for this is something called Oncotype DX. But we have known probably since 2019 that Oncotype DX does not perform in the same way for African American women. So there were several studies that showed that Black women, for the same recurrence score, did not do as well. So the average recurrence score for all races was 17. So you can see on the slide for Black women, 17, white, 17, Latina, 17, Asian, 17. And 17 represents a low risk score. So if you have that score, it suggests that you don't need chemotherapy and should get well with just estrogen blocking therapies. However, a large study was done, 86,000 people, which showed that Black women for that same score had a much higher mortality rate. And the conclusion was that it needs to be recalculated for African American women. However, that test is still used very widely in estrogen receptor positive Black women, even though we know it underestimates their risk. One of the reasons for this is when African American women, even with estrogen receptor positive breast cancer, can have a subtype called basal, which is basically triple negative. So even though it wears a drape of looking like it's estrogen positive, in African American women, more frequently, it will still be or behave like a triple negative breast cancer. And there is a genomic test that calls that out. It's called MammaPrint Blueprint, which does a deeper subtyping. So you pick that up in African American women. And this study showed that if African American women were tested with MammaPrint Blueprint, then it doesn't underestimate their risk, and their outcomes were exactly the same as white women. So you can see if MammaPrint Blueprint said that an African American woman was low risk, then her outcome was actually a little better than somebody who was white at 100% versus 97% accuracy. Same thing with high risk luminal and basal. So I want you to walk away aware that if you have or know someone who has estrogen receptor positive breast cancer and they're doing this testing, that they should ask for MammaPrint Blueprint, because Oncotype recurrence score is not as accurate. And that in and of itself, that awareness and education will help improve outcomes for us. So let's go back to the focus on triple negative breast cancer. And a clue with triple negative breast cancer is an association with BRCA1 and BRCA2. So many of women with triple negative breast cancer will also have an inherited mutation in BRCA1 and 2. This was traditionally thought to be associated most closely with Ashkenazi Jewish women, but it turns out that the prevalence is actually higher in African American women. So if an African American woman comes in with triple negative breast cancer, she has about a 25% chance of having a BRCA mutation, whereas with other people, it's about 12%. So when we see triple negative breast cancer, it's important to think about genetic testing. So what does family history have to do with this? Well, a lot. If you have a strong family history of people with breast, prostate, pancreatic, or ovarian cancer, those are all clues that there may be a BRCA mutation running in the family. But family history alone is not enough. And even if you don't have a family history, if you get breast cancer, you should consider doing genetic testing because it may help you and it may help other family members. The reason why family history isn't always accurate is one, families are not always as close as we think. Like you may know a lot about your mother's side of the family or your father's side of the family, but maybe not both. Sometimes people, the families are not as close as maybe they could be, and we've all seen that. And then sometimes people just didn't know, like back in the day, people died of things and no one really knew what they died of, or they died of cancer, but they didn't know what type. So sometimes the medical history is vague and you're not sure. So when should you think about evaluating your risk and consider genetic testing? Well, talking about both your paternal and maternal family history, if you are diagnosed with breast cancer, ovarian cancer, men with prostate cancer, or anyone with pancreatic cancer should think about doing genetic testing. You can ask for it to your primary care doctor to be referred to a genetic counselor or to ask for testing. And that testing can be done either by blood or saliva. And one of the important points I want to make is if you do genetic testing and it's negative, that doesn't mean that you have no risk for cancer at all. So you still should do recommended screening. And testing is very affordable. When it first started, it cost about $5,000 to just test for 2 genes, BRCA1 and BRCA2. But now it's about $250 to check 81 genes. And if you have a diagnosis of cancer, almost always the testing is covered by your insurance, so it would be free. And if you test positive for a mutation for a set amount of time after that, they will actually test other family members for very little cost, for nothing to up to maybe like $50. So it's important if you are tested and are positive to let other family members know. So why are we talking about this tie between breast and ovarian cancer? Well, BRCA1 is one of the mutations that we find. If you have this, you see a young onset of breast cancer, so early ages, like we see in Black women in their 30s, often triple negative breast cancer. And if you have this mutation, you have a 60% chance of developing breast cancer over your lifetime. With BRCA1, the risk of ovarian cancer is also pretty high. It's about 40% over the lifetime compared to 2% in people that do not have a BRCA mutation. It also increases the risk for prostate cancer and more aggressive forms of prostate cancer in men, and increases the risk of developing pancreatic cancer slightly. BRCA2 mutations, on the other hand, are seen in young and actually middle age, so a little later onset sometimes. The breast cancers more often are estrogen receptor positive, and BRCA mutations are the ones that you see men developing breast cancer. So if a man develops breast cancer, should be getting genetic testing. BRCA mutations also increase the risk of developing ovarian cancer, although not quite as much as having a BRCA1 mutation. Prostate cancer is higher for men with BRCA2 mutations, as is pancreatic cancer, more common in both men and women who have BRCA2 mutations. So recommendations for risk reduction if you're found to have one of these mutations is one, it helps us to enhance screening. So for breast, you can have elevated screening. For women, we would start getting mammograms and MRIs in their 30s, and women can consider prophylactic surgery. So removal of the breast tissue reduces that risk from 60% down to about 2%. And I have pictured here 2 women who all already have had their breasts removed. So these women have had mastectomies, what's called nipple sparing mastectomies. And you can see it looks pretty good. So it's not the same as what God gave you, but not bad. The other thing we recommend is a risk reduction for ovarian cancer is removal of the fallopian tubes and ovaries. So we've realized that ovarian cancer actually, for most mutation carriers, comes from their fallopian tubes. So if you're young, we recommend removal of the fallopian tubes and not the ovaries until you get a little older, because the ovaries producing estrogen is good for your bone health and your heart health. But once you get to your 50s, then definitely both tubes and ovaries is the current recommendation. We can actually screen for pancreatic cancer, and we're curing people because we find it when it's really small. So that's another benefit of doing genetic testing. If we know, then you can get MRIs of the pancreas or something called endoscopic ultrasound, which is just like, looking in the esophagus and stomach or upper endoscopy, but using ultrasound to look at the pancreas. And we can find something as small as 1 centimeter, and then that person is cured. The same with prostate cancer. If we know that there's a mutation, then we begin checking PSAs early. And again, early detection leads to better outcomes. So the other important thing about genetic testing now is that there are drugs that are targeted towards BRCA1 and 2. So it may actually improve outcome if you've developed breast cancer and we know that you have a mutation. Targeted therapies with PARP inhibitors improve outcomes for breast and ovarian cancer. This is like a staple and has really improved dramatically the outcomes for ovarian cancer. The same is true of prostate and pancreatic cancer. So there's a tie-in between all of these. As we started out, there's 6 degrees of separation. So these are all tied together. So let's close with remembering that anyone that has triple negative breast cancer may signal a possible BRCA mutation, that ovarian cancer, having that also should always be a reason to get genetic testing, as it can be a signal of a BRCA mutation, and it also may help us to improve the therapies available. A family history of pancreatic or prostate cancer can have a tie-in to development of ovarian or breast cancer. And that testing helps us to know more and do better for families, because if we know that there's a mutation, then they're screened better, there's earlier detection and better outcomes. So that improves cure. And finally, I just want to close with reminding everybody that we have a lot of opportunity to improve outcomes for our communities around education for genetic risk assessment and testing. And that knowledge is power, because it allows for better screening, early detection, and that we are learning more about how heredity impacts outcome. There's something called Duffy null that I don't have time to talk about today, but it's very prevalent in Black and Middle Eastern women, and it may impact the kind of dosing on drugs that are given to treat cancer. And to remember that MammaPrint Blueprint is a better test for Black women with estrogen receptor positive breast cancer. So thank you for your time and attention. My pleasure.
Next, we will have a video on environmental exposures that will be that is being presented by Dr. Tracy Infair, who is Assistant Professor of Oncology, Office of Minority Health and Health Disparities Research and Cancer Prevention and Control Program from Georgetown Lombardi Comprehensive Cancer Center. You ready for the video now?
I'm delighted to be joining you today to talk about what are some of the similarities and relationships between breast cancer and ovarian cancer. So first, I'd like to note that I don't have any conflicts of interest, and I deeply appreciate the Thelma D. Jones Breast Cancer Fund and the Ocean Charitable Organization for allowing me to join you virtually when I unfortunately had a conflict and wasn't able to attend in person. My research, which I won't be presenting today, is supported by the Georgetown Lombardi Comprehensive Cancer Center, as well as the National Institutes of Health. So my goal in our few minutes together is to give a little bit of a brief overview about, how often breast and ovarian cancers are diagnosed in the United States, who gets diagnosed with them, and then a little bit about why do people get diagnosed? Why do people develop these cancers? And as you see on the right, there will be so many amazing speakers today, so I don't want to steal anyone's thunder, but just kind of give us a little bit of a shared language and shared understanding, so to give some nice framing for their areas of expertise. So first, what is breast cancer? What is ovarian cancer? So the picture you see on the left shows you a human breast with the lymph nodes and vessels that carry different fluids and nutrients to the breast. You have the lobe, which are the milk-producing glands, as well as the ducts. So men can also be diagnosed with breast cancer, and the difference there would be that men typically do not have lobes in their breast. On the right, you see the female reproductive tract. And so ovarian cancer primarily arises in the ovaries, which are these gray areas, and possibly from parts of the fallopian tubes, which are the kind of wiggly finger-looking parts at the top. But how people get diagnosed differs a little bit between breast and ovarian cancer. So for breast cancer, we have screening, which is regular self-exams where a person may touch their own breast around the same time each month to see if there are any changes over time. Clinical exams, when someone gets an annual physical, where the clinician will feel their breast to see if there are any changes. And we have mammography guidelines so that every person who is 40 to 74 years old, who identifies as a woman, and is at average risk for breast cancer should get a mammogram about every 2 years. People who are not at average risk and maybe more at risk than the average woman may need a breast ultrasound or more frequent mammograms. For ovarian cancer, we don't typically have a recommended screening. Some people who may be at higher than average risk of ovarian cancer, and we'll talk a little bit later about what that is, may have a transvaginal ultrasound that provides pictures of their internal organs to the clinical team, or they may have a blood test for CA-125 to see if there are any changes in those levels that suggest they may have ovarian cancer. For ovarian cancer, the symptoms are kind of common, right? Abdominal bloating, feeling pain in the stomach, feeling full, frequently needing to urinate, are common for a couple different diagnoses, which means that oftentimes women with ovarian cancer get diagnosed later after their cancer has started to grow. Whereas people with breast cancer may have lumps that can be felt, may have breast pain, may have changes in the size or the shape of the breast, changes in the skin of the breast or in the armpit, or unusual discharge from the nipple area, which may be more likely to lead to a cancer diagnosis than some of the symptoms for ovarian cancer. For both breast and ovarian cancer, we can diagnose the cancer itself through a biopsy, whether it's a needle or a surgery that takes a piece of the area that may be cancer and then is looked at in a lab. Or there may be a surgery to remove a part of the breast or all of the breast, which is lumpectomy or mastectomy, or surgery to remove the ovary or other parts of the body. So who gets diagnosed in the United States? Well, for breast cancer, it is the most commonly diagnosed cancer among women globally and also in the United States. On average, 1 out of every 8 women will be diagnosed at some point in their entire lifetime. And about 1 out of every 100 breast cancers are actually diagnosed in a man and not a woman. And so what you see on the figure to the right is the age of diagnosis, kind of how often people are diagnosed by race and ethnicity. where at younger ages, it seems that there's more people of more groups being diagnosed close together, although fewer people are being diagnosed. And at older ages, you see more people are being diagnosed who are white, although that difference starts to shrink at older ages, where you see the gray line, which is the white women, and the light pink line, which is the Black women, coming closer to one another at age 85 plus. Next to that, we see the age of death. For this one, the story is a little bit different, where you see the light pink line representing Black women being higher almost across all of the ages at death for breast cancer survivors. And then you see the kind of darker pink, which is the American Indian Alaska Native, spiking in the early 70s. So this shows us that there are some differences in who gets diagnosed as well as who dies of breast cancer in the United States. For ovarian cancer, which is the 11th most commonly diagnosed cancer in women, only 1 in 91 women will be diagnosed at some point in their entire lifetime, but they're more likely to be diagnosed once the cancer has spread compared to breast cancer. However, only people with fallopian tubes or ovaries who are born female can get diagnosed with ovarian cancer. So why is it that some people get breast and or ovarian cancer? Well, in the United States, more than 300,000 invasive breast cancer cases are diagnosed every year. In women, more around 2,800, so 2,800 among men, and almost 21,000 ovarian cancer cases among women in the US. But why might that be? So that's why we think about what are risk factors. And so the National Cancer Institute defines risk factors as something that increases the chance of developing a disease. Some of those risk factors are things that we cannot change, like genetic risk factors. So the most well understood genetic risk factors for breast cancer and ovarian cancer are what's known as the BRCA1 and BRCA2 mutations. So these genes, called breast cancer genes, BR, breast, CA, cancer genes. These genes affect how our cells grow and how they fix damage to our DNA. Some of what we learned that for BRCA1, people who have a BRCA1 mutation are 50 to 85% more likely to develop breast cancer over their entire lifetime, whereas people with a with a BRCA1 mutation are 40 to 60% more likely to develop ovarian cancer over their entire lifetime. For BRCA2 mutations, it's a little bit weaker for, pretty similar for breast cancer, but a little bit weaker for ovarian cancer. But there are many risk factors that are not genetic that we may be able to change. So this figure shows some of the things that are different between breast and ovarian cancer, where people who have been diagnosed with benign breast disease, have experienced radiation to their chest, have engaged in healthy alcohol drinking, or have used some oral contraceptives for 10 or more years, may be at increased risk for breast cancer. They may not be at increased risk for ovarian cancer. Likewise, someone who's been diagnosed with endometriosis may not be at increased risk for breast cancer. But when we look at the link, the overlap between the two, we see that older age increases risk of both breast and ovarian cancer, as does family history of either cancer, obesity or extra body weight, and several other things. One of the important things to note is that family history of cancer may suggest some genetic risks, but a lot of people don't know their genetic risk, and they may not have been tested for BRCA1 or BRCA2 mutations or any of the other genes that may be related to breast or ovarian cancer. So it's important for us to learn our family history, and if someone's been diagnosed with one of these cancers at a young age, younger than age 50, to also be tested if we can. And that's an important thing for genetic counseling, to think about what our risks might be and what level of information we're really comfortable having. But at the bottom of this list, you see exposure to certain chemicals. And this is an emerging area of a lot of interest in the cancer field. So there may be an increased risk of breast and ovarian cancer with exposure to certain chemicals like air pollution, which we may not have as much control over, but also from personal care products like hair dyes, chemical relaxers and straightening products, and other beauty products. And that's because these products often include chemicals that are known to increase cancers or may affect how our bodies respond to hormones, known as endocrine disrupting chemicals. One very recent study looked at risk of breast and ovarian cancer and a variety of personal care products. So in the picture that you see to the right, you see that there was an increased risk of breast cancer for beauty products, but it was strongest for the postmenopausal breast cancer risk. For ovarian cancer, you see an increased risk for beauty products as well as hygiene products, but for both, there may be a decreased risk of skincare products. The reason that this is important is because we very rarely use one product at a time for years and years. So it's important to think about what are the variety of products and chemicals that we may be exposed to among the things that we can change. So I hope in our time together, I've met the goal to give a brief overview of how common breast and ovarian cancers are in the United States, as well as what may be some of the genetic and non-genetic risk factors that are important for decreasing or managing our risk of cancer. So with that, I thank you for your attention, and I hand it back over to the organizers.
For that informative and enlightening presentation. And from that, as well as the presentation from Dr. Johnson, I know already our knowledge regarding the link between breast and ovarian cancer is increasing. Am I right about that? Okay. Thank you again. And next, I should just ask if there are any questions. I'm not sure if Dr. Johnson has left already, because I do know she had a conflict at the board meeting, so she may have moved on in light of the fact that we were a bit off schedule. Okay, so in both of the presentations, we heard the word genetic testing quite a bit, and especially why it's important. Now, to put a combined and or maybe a different spin on what is genetic testing and why it's important, we have our next presentation on just that, genetic counseling and testing. I might add, I have taken genetic testing. So we have with us Barbara Harrison, who is a genetic counselor from Howard University. So please join me in welcoming Barbara Harrison from Howard University.
So thank you so much. I'm honored to be here to be able to share this information with you today. I did work at Howard University. I've been there for about 30 years and have had the pleasure, the joy, the honor of working at that institution and serving our patients. And so today I'm looking to really share with you some information about this link between breast and ovarian cancer. And as you already heard from Dr. Johnson and Dr. Bethea, that genetics is really the key in thinking about the link between these two. And we often jump into this conversation about genetics and talking about BRCA1 and 2 and all these different letters, and don't always backtrack to talk just a little bit about genetics. And so I always hate to assume that people know a lot of information about genetics and really what kind of that link between cancer and genetics is. So I'm just going to take a minute to do that. So let's go to the next slide. So I just wanted to share a little bit like what is genetics. right? And it's sort of things around. And so our genetic information is essentially our DNA. And it's just the information that tells our bodies how to function, right? So it tells us things like, things that we probably think is easy, eye color, hair color, how we are, you know, why we look like our family members, those types of things. But within that genetic information as well, is the instructions for how our bodies built on the inside. So how our muscles move, how we digest our food, how our brain operates. Now, all the information that was needed to go from that embryo to a full live person, right? All that information in our genetic information as well. And so we have about 20,000 individual pieces of information, about 20,000 genes that all work together to provide that information for us to develop. And of course, we get half of that information from the egg and half of the information from the sperm. And for all of our genes, so whether it's BRCA1 or 2 or any of the 20,000, we get 2 copies of that because we get 1 copy from our mom and 1 copy from our dad. And these copies are kind of like versions. So if you think about something like eye color, you have different variations or versions of eye color. You have blue eyes, brown eyes, green eyes, hazel eyes, right? And so variation is fine. Variation is what leads to the difference that we see in each other. But we know that sometimes that variation can be associated with the disease or a condition. So how is cancer then related to genes? Well, you know, what is that? Go to the next slide. So our genetic information can also, in addition to all those things that we talked about, also has the instructions for how our cells are supposed to operate. And of course, our bodies are made of cells, yeah. Hair cells and skin cells and breast cells and prostate cells, right? So you have all of the cells that are following these instructions to do the job that they are supposed to do. Now, sometimes there can be damage or problems that occur in our genetic information. And that damage can occur in some of the things that we've already heard about from the other speakers. So things in the chemicals in our environment. There's UV rays that come from the sun. There's radiation that's coming out from the ground, right? Things that we can't control. Chemicals in the air that we're breathing. And so when those chemicals can get to our DNA, sometimes it can damage our DNA. But our bodies are phenomenal, right? God created us as wonderful beings. And so we can actually repair our DNA. But those repair mechanisms, that way that we repair DNA is also in that, it's in our genetic information. And so for some individuals, their repair machinery, I kind of, when I explain this to patients, I often liken it to like the spell check, like you have on your computer, that if you spell a word wrong, the computer can go in and correct it. Well, sometimes that spell check machinery isn't working at 100%. Sometimes the instructions that you receive from the egg or the sperm for that repair machinery isn't working ideally. And so even though for the most part, your body or that person's body will be able to repair if any damage occurs, it may be that one of those changes might get through and persist. And if that occurs, that can start to change the behavior of that cell. And so a person can be born with a change in that repair machinery. So you're not born with cancer, but you're born with a higher likelihood that some other damage might occur through the UV rays or through the alcohol or smoking or the chemicals in the food that we eat or whatever it might be. And that repair mechanism doesn't catch it. And so that's why you think about genetic causes of cancer. One of the red flags that we look at when we look at that family history that's already been talked about is one of the red flags is a person developing cancer at an earlier age than what you would expect. Because most people who develop cancer, and it's not related to genetics, it's because of the damage they've accumulated over their lifetime. But if someone is young, 30s, 40s, and develop cancer, then you start to think, okay, maybe there's something else going on there, something that made them more susceptible that they were going to develop cancer. So that's kind of this link between genes and cancer. So you can see at the top are kind of what cells are usually doing. And then at the bottom of my graphic are what you see, some characteristics of cancer cells. They don't grow the same. Some people have heard of HeLa cells or Henrietta Lacks cells. And so those Henrietta Lacks cells were cervical cancer cells, and they are literally immortal. They do not die. Most cells have a lifespan, maybe 3 months, maybe a year, it kind of depends on the cell. But these cancer cells, not just hers, but in general, tend to be immortal. They live for a long time, and then they're continuing to develop. So when you start to think of a cancer, you kind of think of that tumor, this massive cells. Most cells, if they start touching other cells, will stop growing. But cancer cells continue. And again, it's because they had a change in those instructions that made them less sensitive to the fact that they're touching other ones. They just keep growing and growing and growing. And then they start changing their function and doing other things. Right. So we know that that link as far as genetics is really important when we think about the characteristics of cancer. All right, so let's get to the next slide. So when you think about these inherited causes of cancer, then again, majority of people who have developed cancer, it is not specifically related to these inherited causes. This is what we call sporadic. Again, this is caused by things that are in our environment. But then we have about 10%, we say, of cancer overall is likely due to these kind of stronger inherited causes. And these are some of these things we can actually test for. So if we go to the next slide, what I've done here is shown a graphic that lists some of these specific genes. And let me pause to make the point. We all have these genes, right? They all have a role in how our bodies are normally supposed to function. And many of these genes, kind of getting a collection of letters here, but many of these genes are involved in that repair of DNA clots. And so again, if it's not operating optimally, that makes us more susceptible to cancer. And so what are the main points of this slide is that a change in a gene that's associated with cancer often doesn't only impact the risk to inherit or to develop one type of cancer. Right, and so we talked about that a little bit with the other speakers as well, when they talked about the link between prostate and pancreatic and breast and ovarian, right? That these cancers kind of cluster together when you look at from a causative and genetic causative standpoint. And so that change in BRCA1 or BRCA2 not only increases the risk of breast cancer, but also for ovarian cancer and other ones. And you can see other examples here on this slide. And that's why, from that family history perspective, when I take it, I don't just ask about breast cancer. I asked about all these other things. And it's also why I'm glad that other speakers made the point about the importance of family history. Why it's important for us to be open about medical history, to share this information with family. Just yesterday, I actually met a woman that has breast cancer. And when I first took her family history, she said her sister had cervical cancer. She was from, at least she was from El Salvador. And she said, my sister had cervical cancer. But she goes on to say that the cervical cancer spread and her sister ended up passing away from cervical cancer. Now, that's not really typical of cervical cancer. But also understanding she's in El Salvador, medical care isn't great, right, all the time. So that definitely could have been her story. I meet her in person a couple weeks later, because we're actually going to talk more, do this testing. And it ends up, she said, you know what, as we were talking more about it, and I mentioned again, like, yeah, it's unusual that a person with cervical cancer would have this problem. It sounds actually a little bit more like ovarian cancer that can be more aggressive and can often spread before you identify it. And she was like, oh, you know what? I think you're right. I think she actually had ovarian cancer. Right. And it was just when having that conversation and she had talked to some other folks in her family to have found that out. And so that by itself was enough to now push her into a higher risk kind of category and thinking of the likelihood that the cancer in her family and herself was genetic. So again, being open about that. And unfortunately, you know, cancer is something that people didn't talk about a lot. They still don't talk about it as much as they could. But it is important for us to be open about it. So if you go to the next slide. So as again, has been mentioned by the other speakers, having a change in these genes increases the risk to develop certain cancers. And so I added in my slide, because I know we talk a lot about BRCA1 and 2. And BRCA1 and 2, when we look at genetic causes of breast cancer, does account for about 40 or 50% of genetic causes for breast cancer. But there are many other genes. And so I threw one up here. And the reason, one of the especially to memorize these numbers and really even think about them too much. But what I wanted to really point out is the difference in the risk that can be imparted by these genes. So one person's genetic risk is very different than another person's genetic risk. And so it's important to, make sure you're talking to your healthcare team to really understand what those chances might be. The other thing for this to point out, and again, other speakers have made, it's not just about women, it's about men. Having that brother with prostate cancer can put his sister at an increased risk for breast cancer and vice versa. And you can see these other cancers as well. And so if we know this information, the chances to develop other types of cancer, even the chance for a woman with breast cancer to develop breast cancer later on after she's gone through treatment, what's the chance for it to come back? That's that second row there, that contralateral breast cancer. What's the chance for it to happen again in 20 years, either in the same breast or in the opposite breast? And there's always a risk. If you develop that first column is kind of the population, kind of the risk that everybody faces, and then the increased risk you face if you carry a variant in one of these genes. So that chance is always there, but it's going to be higher in the person who carries this genetic risk. And so if you go to the next page, and we have heard about this from some of the other speakers as well, kind of what is the impact of, if you identify one of these changes, how does this even change my care? Why is this even worth me finding out? It's because it can impact how we take care of you. So for that person that has cancer, as has been talked about by Dr. Bethea and Dr. Johnson, it can gear us toward different chemotherapy options that we might have to treat that person. It can lead to even changes in a conversation around surgical intervention. So if there's a person who has breast cancer, and maybe it's small, we caught it early, and so we could do a lumpectomy. But if I know that person has a higher risk that cancer is going to come back, it may inform the discussion around maybe we should remove the breast. You don't have to, but it can inform, it can provide us better information to know what might be coming down the pipe and how we might try to avoid that additional cancer from occurring. So that's for the person with cancer. For the person without cancer, if we identify that there's a gene in the family, a change in the gene in the family that's increasing the risk for cancer, and now you test the person who doesn't have cancer themselves for it, well, that can impact how we'll manage that risk, right? So that managing that risk might be, instead of coming in for mammograms every year, you come in every 6 months. And maybe we don't just do mammogram, we alternate a mammogram and MRI. That's a different way to visualize the breast. And we may not wait until 40 to start those mammograms. Maybe we'll start them at 25 or 30, right? Because early detection is always the key. That's our best tool against cancer. In addition to that, it may even open the door to surgical intervention for that individual. So even though they haven't developed cancer yet, some might choose, let me just have my breast removed and reduce my risk of breast cancer in that way. Or let me remove my ovaries, because I increase risk for ovarian cancer, but when you remove the ovaries, it actually decreases the risk for breast cancer. So there are different ways to manage that. And it may be, I don't want to do that at 30, but maybe that's something I'll think about when I'm 40, right? And so there are different ways that those discussions with our healthcare team can be informed by having this information. And then, of course, we can from there identify other family members who might get breast and might benefit from this information. So in the last probably minute or so I have, let me talk a little bit about how genetic testing is done. How can you access it? So most of the time you get a referral from your physician, your healthcare team to get to a genetic testing. to get to a genetic counselor rather than facilitating that testing done. Some physicians in their practices are able to actually do that genetic counseling and do genetic testing right in the office. And then they can refer if it comes back positive or something like that. It can be very office dependent. But then you can also get testing through the internet. And I like to mention this because it's out there. Right? We have heard about the 23andMe's and the other companies that they can mail you a kit and you spit in the tube and you send it back and they give you information. And so I will say for medical purposes, that is usually not the best way to go. Now, you may certainly get information about your ancestry and whether your pee smells like asparagus or whatever, other things that they come up with that they can get from their genetic information. But as far as that clinical information, oftentimes that information is not so much inaccurate, it's just usually not complete. So I'll say, for example, for breast cancer, they will look at BRCA1 and 2, but often they just look for 2 or 3 variants within those genes. And if you come back negative, they say that you're negative. But indeed, there's thousands of possible variants within those 2 genes. You just may carry one that's not covered in the testing that they're doing. Or maybe you carry a gene in that PAL-B2, which was that last column that I had. It was another gene that's associated with breast cancer that they just don't do testing. So it's not so much that it was wrong, it just wasn't complete. And so that could be a challenge. And so I think it's best if you really have that family history, you have a concern that you talk to your healthcare team about it. That being said, though, again, some people do take that route. We can go to the next slide. So that talks a bit about some of the goals of genetic counseling. So if you are referred to a genetic counselor, what we will typically do is that I will sit down and take that family history and really have this full discussion about what is, what are genes, what's genetics, what's the connection with cancer, what are the different options we have as far as what testing to offer you. And really assess the best test to do. If there's only a family history of breast cancer, I might only look for 13 or 14 genes. But if there's a family history of colon cancer, kidney cancer, other things going, I might expand that to 70 genes or 100 genes, right? But the genetic counselor can really be best kind of positioned to make that decision about what is the best test to do. And then dealing with those test results afterwards, that fallout afterwards. And thinking even about that ahead of time. How is this information going to be helpful to you? How are you going to process this information? How are you going to talk to your family members about it? And what can I connect you to? There is a whole community out there of people who support individuals that have genetic causes for their cancer. They have groups called pre-fighters. So those are the individuals that don't have cancer yet, but carry a gene that increases the risk. So a whole community of support for them as well. So sometimes these are ways you can get yourself connected to others that can help you, as well as phenomenal organizations like patients. Now, and so if you go to the next slide, just some questions you may want to have in your mind. If you do have genetic testing, just really being clear with your provider about how this information will be used. And then some people have questions about insurance, about what we call genetic discrimination. So is there any way my health insurance is going to use this information against me? And I will say just, quickly that there are some legal protections against that in health insurance, but there are not those same protections with life insurance and disability insurance. And so sometimes that's a conversation that's, or a point that's part of the conversation when you're considering doing genetic testing, particularly people that don't. So with that, I think that ends my yes. So I'm definitely getting around for questions. And just again, very honored.
Thank you so much. What an excellent presentation. I like how we said that we were backtracking and providing more in-depth knowledge and understanding on what is genetics. So we appreciate you taking us from the beginning and also building on the information that both Dr. Johnson and Dr. Bethea provider. So please convey my thanks to be spent at our university cancer center for recommending you, great recommendation, and I might add, I serve on our university's community advisory council. And so that's my connection to our university. And also, while I love to get all of the speakers back at some time, I particularly would like to extend an early invitation for you on Wednesday, December 17th. As I mentioned earlier, the Thelma Jones Breast Cancer Fund every December has that conversation, and the information you provided will really be helpful during that meeting. So I will follow up to see if you are free. And we know it's important to have on busy people's schedule very early. So now that we have had four excellent presentations on really bringing us up to speed and broadening our knowledge on what we are here today for, that is looking at what's the link between breast and ovarian cancer. And I think the speakers have done an excellent job in that. So now we are going to hear a different side, which is on behavioral health by Dr. Robin Kennedy, who has a number of advanced degrees, as you see on the program. I won't embarrass her by reading all of them, but I want to make sure that y'all have a copy of the program. This is Dr. Kennedy's second time speaking to the Thelma Jones Breast Cancer Fund within a few months. She is also my neighbor here in Southwest, so I feel that I'm very fortunate to have her. She's an international psychologist, author, and a faculty member at the Chicago School of Professional Psychology and George Washington University, which is not too far from here. And Dr. Lulu will speak on the topic beyond the diagnosis, mental health, resilience, and the cancer journey. So please join me in welcoming Dr. Lulu. And after Dr. Lulu speaks, we will have our fireside chat. The sofa was a little too heavy to breathe, so we're going to place a couple of chairs up here later on, and appreciate if our gentlemen in the audience would very happy to have for help set up the chairs. Please welcome Dr. Lulu. Thank you.
I'm so honored to be here today. I was not feeling that. This is something I could not miss. It's so important to me, and I really appreciate hearing all of the presenters today. I've actually learned quite a bit of information. Definitely interested in genetic testing now. But I'm going to talk about a different side of this, the link between mental health. And I've been in the psychology field for 28 years now. And I think people often overlook mental health as a topic that's very personal to me. I'm going to talk about this a little bit in my talk today. I lost my same-age cousin as a result of cancer a few years ago, but really focusing on the link between our mental health and our minds. So thank you again for welcoming me into what I consider to be a very sacred space in one of your presentations. So my goal again is to go beyond the diagnosis. We talked a lot about the diagnosis, and that's not to deny the body, but to awaken the mind. Because I believe, and I will say this every time that I speak, I honestly feel like the most powerful muscle in our body is actually the human mind. And cancer is a medical condition. It is. But healing is spiritual, it's emotional, it's psychological, and it's mental. And so, no, I'm not talking about PET scans and prescriptions or anything like that. But what I want to talk to you about is what I think is the most powerful force that you have, It's your mind. And I think many people, many experts who work in the field will agree that many people underestimate the power of your mind, your thoughts, your inner dialogue, which you say to yourself in the middle of the night when no one else is there. And I want you to hear me really clearly. And this is for all of our speakers on Zoom as well. Your mind can either be your medicine or your poison. Your mind can be your medicine or your poison. It can build you or it can break you. It can heal you or it can harm you. And in many ways, it can determine how your body responds to everything that you're going through. So I want to go a little bit deeper because you know how they say pain is in the body, right? They always say pain is in the body. Not entirely true. Not entirely true. Pain is interpreted by the brain, So when your body is hurting, it's your mind that encodes that pain, tells it how to feel, right? And so let's flip that. That means your mind can also tell your body something else. We're going to fight. We're not giving up. Joy is possible, even here. Your body receives instructions from your mind like soldiers taking orders. And the quality of those orders really comes down, it becomes the quality of your feelings. That makes sense. So this is why you can have two people who have the same diagnosis, the same chemo, the same treatment plan, the same surgery. One gives up, one comes alive. And that's not just biology, that's psychology and that's mental state. So I'm gonna go a little bit deeper for a moment because there's a field that's called psychoneuroimmunology. And it's the study of how your thoughts impact your immune system. And it's not fluff. It's not just be positive, be positive. No, it's science. Studies have actually shown that people with strong support systems, social support systems, people who have high self-efficacy, right? Who believe in themselves, people who have gratitude, who practice gratitude, being grateful, right? Being grateful, I'm just alive, I'm breathing, right? I'm alive, who practice gratitude, who are future-oriented thinking, and I'll talk about that some, I did my question. Future-oriented thinking can recover faster, can tolerate treatment better, can experience less pain in some cases, and can even live longer. And it's not magic, it's mental mastery. And so I started to question myself, and this is something I'm focusing on a lot in my work. Why don't we talk about that? Why don't we hear about that? And what I realized is that we've been taught to survive, not mentally thrive, right? To survive, not mentally thrive. And especially as Black women, right? Especially as Black women, we've been conditioned to suppress, to perform, to endure, right? How many people have been told, be strong? Be strong, don't complain, hold it together, right? Pray about it. And yes, pray, but also process, but also retrain your mind, retrain your thoughts as sacred. Because your mind is the command center for your body, right? And so if it's your command center for your body, it can be your healing terrain, right? It's a command center for your healing terrain. And so what happens is in the middle of that pain, your mind is also flooded with fear, with shame, with loneliness, with conflict, and the very spaces where you're supposed to feel safe. Then the body follows. The immune system responds, and the healing process slows down. But the reverse is also true, because when your mind receives hope, when your mind receives clarity, when your mind is spoken to with intention, with joy, with love, in any space, right? Something shifts. You know, I'm an international psychologist, and I'm gonna go off track for a moment because I'm traveling constantly. That's probably why I'm sick right now. But I was in South Africa a couple of weeks ago, and I've been to South Africa many times. I'm going back in a couple of weeks again. But this time, every time I go someplace, I try to go. I'm very mindful, and so I try to go with an intention of being present. And so this time when I was there, I don't know why, I was just really centered more on Nelson Mandela, right? Nelson Mandela. And in his story. And I started to think about how he not only endured, right, so many years of harsh incarceration. I mean, harsh. It's not the prisons that they have now. I mean, literally a tiny box, not being able to communicate with his wife and so forth, right? Not being able to see his family and his kids for so many years and still coming out and being joyful, coming out and being intentional. It was because of the mind. Does that make sense? He was very intentional in how to process this. And so when the mind receives hope, when the mind receives clarity, when the mind is spoken to with intention and with joy and with love, something magical happens. It can shift. And I say to you, I'm not presenting today as just a psychologist, but also as a woman who wants my very dear cousin, my senior cousin, my first cousin, who I've known my entire life since birth, who was like a sister. I watched her fight for her life, while also trying to survive something else just as painful. Toxic family dynamics. And you see, my cousin wasn't just battling cancer, she was also battling. And I remember, she was towards the end, and she was in a hospital, and she was still trying to deal with these toxic family dynamics. She was dealing with people who were draining her, who devalued her, who added stress to her spirit, while her body was already at war. And watching that broke something in me. It broke something inside of me. And I realized that healing isn't just about medicine. It's not just about medicine. It's about the mental environment that we're trying to heal inside of. And all too often, we're trying to heal in places and in relationships that are actively hurting us. And so that experience, watching her fight for not just her life, but for her peace of mind, was one of the moments that led me to create this book that I have right now called the Dark Slayer Bible and its companion journal. Because I wanted to focus on not narcissism as much, but because I wanted to offer a mirror and a method for people reclaiming their mind, their joy, their power. Because the real goal is mental freedom, right? Peace as your baseline, and healing that starts inside and that radiates outward. And so how do we actually do it? Okay, so when my cousin was fighting for cancer, I talked about forward thinking. When she was fighting for cancer, one of the things I noticed was everybody in the family would go, oh, how are you doing? Oh, how are you doing? And they wanted to talk about cancer. And she didn't want to talk about that. Right? She was talking about it. So I never talked about the cancer at all. I never talked about it, right? I went and I said, what are we singing today? I went back to our favorite movies, Karate Kid, right? And I started singing a movie. I remember the hospital said, we're going to close the door. You guys are loud, right? I went back and started singing. I started asking her, what are we doing for your birthday? I said, girl, we got to plan this birthday. What are we going to do? And she just wanted to go to the beach one more time. I said, this is what we're going to do. I was planning a wedding. I told her, I said, this time, he's always lunch. I said, I'm messaging him. I said, we're going to plan your wedding. This is what are we going to do, right? It was, what's your dream vacation? Forward thinking. And she started to feel alive. Does that make sense? I focused on life because the brain, and here's something, you might see all of these videos on YouTube talking about manifestation. A lot of it is real. The brain does not know the difference between imagination and reality. It doesn't, right? So if we keep showing it death, it will prepare for death. But if you show it hope, it will rally. And her body, she started to rally, right? She started to rally. So that's what I'm going to give you today, and everybody watching, not just empty inspiration, but a strategy. A mental resilience framework. And so here are 3 psychological truths that I want you to carry home today. It's like a gift bag for your soul. The first is your mind is your most valuable muscle, but you have to train it, you have to feed it, and you have to defend it. If you come in my house all day long, even my mother the other day, she was visiting me and she said, listen to that video you were playing. I'm constantly training my mind, right? What do I feed my mind? I'm constantly listening and reading and watching for things and talking to people who feed my mind positivity. You have to train your mind like your life depends on it, because it does. You have to talk to yourself like someone worth fighting for. If your thoughts for medicine, I ask you right now, Would they be healing you or poisoning you? Every morning, stand in the mirror, not to judge, but to affirm, I'm worthy. I am healing. I am not what I have been through. Because the mind becomes what you feed it. The mind becomes what you feed it. Feed it fear, it will freeze. Feed it truth, it will transform. Number 2, your nervous system responds to safety. Your nervous system responds to safety. Fear, stress, and despair weaken your immune system. But calm connection, being calm, having connections, gratitude, being grateful, and joy, they strengthen it. So give your body a reason to believe it's safe. And this is something you can try. Turn off the noise, right? Get quiet, light a candle, and speak to your nervous system. You're okay. We're good. Breathe. Practice breathing, breath work. If you haven't, you can look it up. There are free YouTube videos. Breath work is powerful. I'm going to repeat. And then 3, you can choose your inner climate. You cannot control the diagnosis, but you can control your disposition. You can wake up each and every day and you can say, I choose peace. Today I choose peace. Today I choose survive. Today I choose me. You are the weather maker of your mind. I don't care what the scan said. I care what your spirit says, right? Because I've seen it time and time again. A shift in mindset can change everything. I will tell you, I shared this with Thelma before. I had in college, in undergrad, I had a pretty serious blood disorder where I literally was dying, right? By the time I got to the hospital, they said my organs were shutting down, right? And luckily they were able to save me and so on. And so maybe 10, 15 years after that, I started to notice some of the same symptoms coming back, right? But I had 2 young kids. And I was directing a program. I was working, I was busy, but I started to know, I knew something wasn't right in my body. And I started to, feel the symptoms. I mean, I wasn't well and I could feel that, but I had to keep pushing. I did my due diligence and I went to a doctor right here in DC and I told her about my history and what had happened before and asked her, could you please check my blood, can you check because I'm not okay. And she never called me back. I kept calling the doctor's office. They never followed up. And so I had to keep pushing. I wasn't sure. I kept calling, but I had to keep pushing. I had to keep going. And I was at a birthday party with my son, and I got a call. And they said, we're not sure if she's still alive, but if so, we're trying to withdraw her liver. And I said, well, who is this? And he said, oh my God, it's just you. And he says, this is Dr. So-and-so. He's the head doctor of this practice. And he said, the lab just called us and said that it's impossible for you to be alive. You have no blood left in your body. We need you to get to Sibley Hospital right now. And so I really, it wasn't registering for me. It was a lot. I finished at the birthday party. I went home. And when I got to Sibley, I still wasn't understanding. And I gave them my name, and all of a sudden they started plugging all the stuff up to me. I really didn't understand. And this doctor came in to me. He says, I don't understand. You're still working? And I said, yes, sir. I've done the program, and I have 2 young kids. I have to go. And he said, you're still walking around? I said, yeah, I'm living on the floor on me. I have to take the steps. He says, you walk up the steps? I said, I have to stop and take breaks. Because, I could run it, but I mean, what can I do? And he looked at me and he says, nothing in our medical book, everything our medical book said, you shouldn't be alive. He says, it's medically impossible. And this older white gentleman looked at me and he said, it must be a God, right? And yes, there is a God, and it was not my time, but I also think it was my mindset. Does that make sense? My mental mindset. My mind had not given into saying, oh, I'm sick and something's wrong. My mind was saying, okay, we know what I'm supposed to break, but we're gonna keep pushing, right? We're gonna push. So this will not erase the illness, but it can renew your identity. It can restore your voice. It can remind you that you're more than what's trying to break you. So I'm going to leave you with this. You're not your diagnosis. You're not your trauma. You're not your prognosis. You are a mind. You are a miracle, and you are still becoming. You deserve to wake up in a world that is built for you inside and out. And if no one else tells you this today, I want to say it first. You are worthy of joy. You are powerful beyond what you really are. And you are not done yet. I want to thank you, and may your mind be your healer, your friend, and your most fierce protector. Because your mind is absolutely the most powerful muscle in everything in your life. Everything starts with your mental state. We had 20 doctors here. I promise you, they will all say that in the end, it's going to be your mental state that will dictate everything else. So thank you all so much. And again, I will be around as well. Thank you.
What's that? I'm running to it. Thank you so much, Dr. Lee. I don't know if I mentioned that she is my neighbor. We live in the same complex, so I'm feeling the synergy. And I think what you said is a good way of also building on what we've heard from our other three wonderful speakers. As I mentioned in her introduction, this is her second time speaking, and she will be on the list to speak again in the near future. Because it's important to get this mind over body matter thing down, particularly when many of us here are going through a serious disease. And so with that, we are now going to shift from our excellent clinical speakers to our everyday people like Dr. Jones. And we're going to do a fireside chat with Karen Hargrave, who is a two-time breast cancer survivor, advocate, and author, along with Arnett Mutaya, who is a three-time breast cancer survivor. She's a survivor of triple-negative breast cancer, endometrial cancer, and colon cancer. And as my sons Jamal and Jane, if you could help set up 3 chairs for our fireside chat, I'll tell a bit more about these ladies if they're doing that. Great. Yes, facing the audience. And is this, for our technicians, is this the best place to set up? Because we want to be seen on TV. Images morning. So good morning, ladies. Good morning. You're looking quite lovely in your pink and that hat. Where did you get? Isn't she wearing that hat? Now, where do you have and the bottom? And I love thank you. Again, the love that I have. The hat, there were like 15 to 20 of them, and we all got to pick a style. Had I known you were wearing yours, I would have wanted also. And they were, it was a breast cancer survivor. Sherry Dickinson Trott is not feeling well, otherwise she would have been here. And Sherry is someone who is a staunch advocate for people with disabilities. So she is not only a breast cancer survivor. At the age of 16, she had a terrible diving accident that left her paralyzed. But speaking mind over matter, that does not stop Sherry. So I'm happy that she shared those little hats with us. So if each of you could take about 3 or 4 minutes to share your stories with us, so that the audience will have a greater context of the life that you are leading. And which one of you lovely ladies would like to start first? Okay. I love this, I love it.
Good morning, everyone. I'm so excited to be here. My name is Harnett Tyler, and I'm the oldest of 8 children. I have a sister that has been cancer died with cancer, and a niece that has been diagnosed with triple negative breast cancer. So, we're getting about 53 years later. I was diagnosed with that there at that time was completely directly and stage. If the and for that, I could get up at 2015. And it was kind of devastating. I was told that I needed to have respectfully, chemo, surgery for chemo. One that really bad is holding. Very, very well. I haven't thought that I can live again and live the right thing. I got the radiation damage is important. Where I need to have a job. Got to get a job. And then when you get home, I have a friend they were starting. He's not here today. And there's one here I was actually standing up about friends. And she said, I think you really did. President Jones, President before. What we need to do besides it to the complicated to the great guy. She never said, I don't think my name is gas. They only live to go. So many information for all people that have all Here comes the calendar. So, God has always been with me on my journey. And I'm so proud to be here.
I think that's wonderful, and we're going to come back to because there are a few questions I want to ask, or also to remind you to speak about, because you also have twins in your family, and because of the family history discussion we've had, I think the audience would really benefit from knowing about that. Yes, and now, Karen, can you tell us a bit about yourself and your story?
Yes. Good morning, afternoon. Good afternoon, everyone. My name is Karen Hargrove. I'm a 2-time breast cancer survivor. And let's see, I'm just going to start my story with the age I was diagnosed. I was diagnosed, I believe I was 28. And I always teach my daughter, she's the bookmark, the beginning and the end of my cancer story. She was 18 months when I was diagnosed the first time. And through that process, I went through chemo treatment. I guess based on my numbers or my diagnosis, the oncologist thought the best treatment would be chemo. And so my husband would take me on the Thursday, I believe, and then he'll pick up my call on the Friday. So it was 6 weeks, 2 weeks on, 2 weeks off. My treatment was like that. Family history wise, I'm the person I found to be diagnosed with cancer, breast cancer it is. 3 years after I was diagnosed, my mother was diagnosed later. And then after that, she got pancreatic cancer, which that took her out, but yes, she was diagnosed with breast cancer first and then pancreatic cancer. Fast forward, my daughter was graduating from Northwestern University. It was 2018, I was diagnosed again. That's why I say she's the bookmark and the bookend, because my cancer spans her college or education platform, if you will. I was diagnosed again, this time with breast. It was the same, with the chemo and radiation. My treatment was at GW Hospital. I would say kudos to them. They took very good care of me. Breast cancer doctor was on point, oncologist on point, very good service. Again, same treatment, on and off. Support system, family-wise, was on point. Sisters, friends, in-laws, they were there. Husband from day one was there. We've been married 30 years. Kudos to him. They can't handle it. Your body goes through a change. You have scars, so so I'm living proof that family support is a blessing. I have to give a shout out to my mom no longer with me, my sister Cassie, my sister Pam, my sister from a different mother, my sister-in-law Melody Hargrove. They've been there. It's been a journey, and hearing Dr. Luke, I'm pronouncing her name right. I must have been a case study for her, because I can literally say she was speaking about me. Attitude, your faith, your mindset. When you're diagnosed with cancer, your mindset just goes, it's like you're having an outer body experience. You no longer live the life you used to live. Your outlook on life is totally different. You don't sweat the small stuff. Not saying you don't have fear, but you handle it differently. Your mindset is just different. You're sharing your story, you're uplifting, you're encouraging, you have hope. And that's my story.
And so I'll start one question with you. Now, you are an author. Tell us about the book you read.
Yes, so here's the book. Knocks at your door. And how I became an author, actually, the main author, I'm collaborative author with LaDonna. I called her to see how she was doing. She experienced cervical cancer. And I called to see how she was doing. And me being who I am, I'm going to encourage you no matter what your state of mind is, because you may go into a deep hole, but if I find out you're going to do something, I'm going to call you. I'm going to do my best to pull you out. That's just who I am. And she says, "Well, Karen, you're so positive, and I love your attitude. How about doing a book?" I was like, "Excuse me." Was not on my bucket list to do, and I said, "Okay, so let's do this." So 4 of us got together and collaborated our stories into one book, different types of cancer. And so I think it was LaShawna spoke on coming together, because cancer is cancer, it does not discriminate. And so we came together with our stories to uplift, encourage, and provide hope. Yes, it's a disease, but your mindset is a fight as well. And the journey continues. Some people will perish from this disease, but we stand here to say the fight continues. We're here for you. And more information about the book, see me afterwards.
Thank you. Yes, Karen does have a table with some books on it, so we hope you will support her effort. So you talked a bit about your support system and how you and the authors came together. So tell me, Arnett, about your support system and the fact that you are a twin. You are a twin.
I'm the oldest twin, and I have a, brother. He lives in the Berlin area, and we're not that very close. I've always wanted to be a part of a close-knit family, but my sister that's here today, she also is a twin, and she's the baby, but she'll say she's never been the baby. And we are the twin, and she has been support. During other times, my family were busy and they didn't have time. But I want to say once again, God has seen what you need. And so my hope and depression set in, but since what people lift my spirits up.
Thank you. So you share with us how spirituality plays a role in it. Karen, you want to share with us how spirituality plays in your journey?
Oh, heavily. I think that's the key. No matter what you believe in, my faith is it's just. I think I'm here because of that. I believe I am here because of that. Yes, you have medical doctors, but they too are still whether they believe in. That's instilled in them, and if your attitude says fight, you're gonna fight. There's no way to explain it. It's just a great feeling that it just takes control. It's like an authentic feeling, and it grounds you. And I didn't know there's a name for it until the people spoke on it, but it's like a out of body experience. You're really like on a cloud nine. And yes, you're dealing with cancer and you have all these emotions, fear, you think of death, what's going to happen when you're gone, what's going to get your baby, what's going to get your husband. All these emotions go through your head. At the end of the day, something takes over, you're like, okay, I get that, but now I'm a fighter. I'm a child of God, and He's not going to forsake me or leave me, so I'm going to fight. And because I have things I want to live, but He said, do it. Yes, I'm still here.
And the other as well. I have had a whole team without the Washington Hospital Center, and they told me the chemo is just a little too hard for you with all of your challenges, health challenges, and we don't really think you're going to make it. And then I wanted to fire, oh my God, I am going to make it. So when I got about more than halfway, the doctors came in and said, we are so amazed that you're doing this well. And then when I was completed all the chemo treatment, they said, you were able to go through all the treatment. I think because you don't know my guy. He did it once, he did it twice, and I'm newly diagnosed with colon cancer. I don't see any reason why he's not going to be able to train through.
Oftentimes, and we just touched on it because you had other comorbidities. Can both of you share what your health state was like and the medical challenges or conditions that you had in going through your diagnosis? Which of the diseases were you faced with?
I have a pacemaker. The radiation damaged small bowel. Whenever I had a stroke, that's a good thing.
Thank you. Sharing the faith that took you through on this. And Karen?
Personally, I didn't have any health issues. I was pretty healthy. When I was first diagnosed, I was fine, no issues. After I took my chemo treatment 4 years later, I had a son. No reactions to him, no chemo effect was passed on to him. My doctor diagnosed again, no health issues. I was fortunate. Blessed is the word I'm going to use.
So both of you have had, two times in your case. How different was your first diagnosis, your second diagnosis? What did you say basically when you discovered you had cancer the second time around?
First time when I was diagnosed, and I was all about my hair. Because you think of lose your hair. Your hair is your crown, your glory, your beauty. So first time I did not lose my hair. So I was like, okay, fine, no problem. Second time I was diagnosed, believe it or not, I might have called my sister Cassie first. She's an older sister. She was actually getting her hair done. I was not worried about chemo. I was not worried about the surgery. I was worried about my hair. Because I used to wear a bush, and I love my bush. And so what I experienced the second time, it's not fear because I know what to expect. I knew what the treatment was going to cause me, the chemo. I knew how my body was going to react to it. But I can't. I was worried about my hair. So and I knew my fight was going to be. I was ready. I had my armor on. Was I angry? Yes. I'm like, why is this happening again? But my mentality was, you did the first time, I'll do it again.
And what was your reaction like when you discovered you were dealing with a second, and share with us what it was like when you found out a couple of weeks ago that you were going through cancer third time?
Second time. And I was told I had breast cancer and that I needed chemo and surgery. I was kind of devastated. And I just didn't want to go through it. But I wanted to live, so I'm going to do it. It's here, and I'm going to do the doctors have to do. So I would have to take care of myself, push myself, go and do it. And the third time, it's definitely, if you got hard stuff. You become angry, It's like, I forgot one more thing on it, but you first know that I get through this. But I do think, I went to see a doctor that took a test and detected different kinds of cancer in the body. So they did that. And so they called me and they says, it came back that you were at risk for colon cancer. So they said that you need to go to your primary care and follow up. So I did. My primary care says it's a false positive, disregard. So I didn't. I went to see my GI doctor. He said he agreed with the primary care that it's a false positive. And I said, well, I think I want a colonoscopy done, just because I've had a history of, urinary cancer, and that's kind of a red flag. He says, no, you just had a test done 3 years ago, and there's no need to do it again. So with this last diagnosis of colon cancer about 2 months ago or less, I've been thinking about that I felt that I was dismissed and that they didn't take me seriously enough to grant it. So I kind of left it, not having so much confidence in the medical doctor that I need to navigate more or what is that word? And advocate for myself and seek another opinion,
You're absolutely right. We do have to advocate for ourselves. And sometimes as people of color, we even dismiss more. So we do have to challenge it. I know in my case, I had three opinions before I allowed anyone to cut on me because I wasn't happy. So, and that's about advocating. And even when you are dismissed, it's time that we dismiss them and move to someone else and not allow that to be a way that you might be offending the doctors. Which is, I have sisters in North Carolina, and when I'm trying to encourage them to do or ask something is, oh, well, he or she might think it's not about them. It is about you.
Yeah, because my mother is one that whatever the doctor says, go with it.
Yes.
Don't question it. They went to school for many years, they know what to talk about, so they make you sick all the time.
Why do you think malpractice insurance is how it is? I mean, they make us sick, not suggesting that they intentionally do it, but it happens. So this is why advocacy is important. And you'll hear from one of our speakers about the importance of advocacy later on. For both of you, if you had to tell someone, what advice would you give to a person who is newly diagnosed or who's having to deal with a second diagnosis?
Get a opinion.
That's a good one.
Get in a support group.
You can refer them to the Thelma Jones. Shameless promotion.
With a lot of I say to yourself, get information.
Embrace your emotions. It's okay to be angry. It's okay to be sad. It's okay to have fear. And it's okay. Deal with that. But I would encourage that person, don't stay there. And because your mind is very powerful and it can determine your outcome. Reach out to a support group. Be surprised. There's a lot of resources out there for you. Monitor your diet. Read those labels. My husband and daughter tease me, but because that's not good for you. That's not good for you. You can't pronounce those words. You might want to consider going with another brand. I'm not there completely, but it's on my radar. Be mindful. What you put on your body, try to use all natural products, especially when it comes to my deodorant. I'm taking baby steps. Support, resources, and don't go through it alone. When cancer knocks on your door, don't run from it. Don't serve with somebody, not by yourself. It's a big difference.
And there's this motto is drink your water, drink your water. How much water did you have?
Fluid intake. It's very important, and water, because fluid can be sodas and all kinds of other things that's not healthy for you. So we're going to go to the audience to see if you have questions.
In the chat, you don't necessarily have questions, but you have fans.
Okay. So going once. Okay.
Karen, I was diagnosed when I was young also, and I want to know, were you on tamoxifen? Did they give you tamoxifen after the first diagnosis?
I can't recall. I know it's gonna have a medication to help you with feeling nauseated.
No, like after you finish your, you know, they usually give you tamoxifen and you gotta take it for 5 years after. Yes. They don't use that anymore?
For me, my cancer is not estrogen related, if I remember correctly, or they don't recommend that I take anything hormonal. So I'm gonna, no.
No, because I don't take anything. I was diagnosed when I was in my 30s and now I'm in my 60s, so they never given me the now. I was like, well, why don't we get anything anyway? Should I get on it? And then you still had a reoccurrence. And,
Yeah, even recently, my oncologist, when I mentioned it to him, he's like, based on how cancer you had, you didn't recommend it. And this is my second, which is 5 years ago now, 7 years that I've been cancer free. And I still see him yearly now, he does not recommend it.
So I do have, there was one other question. Both of you talk about your family and the family history that you have with cancer. Can you tell me or tell us whether you have completed genetic testing and have other members of your family have diagnosed?
My daughter has been tested. It's been 5 years. My niece, it's been 5 years. For me, it's 10, but according to the second part, it's not.
And of course, if you don't feel comfortable with your doctors, we have a wonderful genetic testing counselor. Yes, you can go to Howard University. Okay.
I was tested twice. The first time it wasn't as extensive, it was as small nature. And then I got it done again where they brought it, again, cancer didn't run in my family. I think I was the first, to my knowledge, that was diagnosed. So of course, I started having to check that box now, medical history. Cancer now runs in our family. Then my mother was diagnosed after I was. My daughter, she had genetic testing. And I think my sister was one that had. So I'm now encouraging them to have it, whether they need or not, just to know. The more you know, that you can be prepared yourself for preventive care. So I would highly recommend it.
John, can I ask something about that in relation to that testing?
Sure.
Mainly to you. If you have, like, say for example, my wife and her mother, we have a son, and I noticed in some of the presentation, it's a low, very low for male breast cancer. But would you recommend genetic testing for a male of a person who has went through?
Yeah, so the interesting thing about genetic testing is, and what makes it kind of different than other types of testing, is it's individual, but its impact is familial, right? And you can use information from another person's genetic test, a family member's genetic test, to help inform what we do for you. And so we had this conversation. So one was the good point of kind of getting retested. I think that's one issue. I'm going to do your question, but I just want to make sure I touch on it. So our knowledge about genetics always changes with time. We are still in the discovery mode, right? And so when Karen was first diagnosed, we may have only known about BRCA1 and 2, and that's what she got tested for. And that was fine. And that was vindicated at the time. She came back negative. And she's saying, like, I did this retest later. That's because now we know about the 13 and 30 genes, that are associated with breast cancer. So going back and just checking in with your healthcare team and seeing if it makes sense to get tested again, I think is always a good move. Now, to your question, so let's just use your family as an example. So she's been tested. We'll just assume for all the, reasonable genes to have been tested for, and we can't find anything in her. And if anybody in the family had a genetic cause, we would have found it in Karen. So I would expect, if we do it in her daughter and her son, we're not going to find anything unless your family's coming with something, assuming that your family doesn't have any genetic breast cancer. If she doesn't have it, she doesn't have it to give. And that's where they would get it from. So my answer specifically to you would be no. There really isn't an indication to test either of our kids, because if we've done the full kind of panel that we can do in her and we haven't found anything, then again, she doesn't have it to give. So it's not like it would suddenly pop up in the kids.
Only if she had something to.
Only if she had something to give. And so so that's the answer in that situation. Now, let's say it's a different situation where that person with cancer has passed on. And so you have reason to suspect that they had a genetic cause, but I can't test that person to know. Then yeah, I'm gonna test the family members around them whether or not they have cancer, because they may have received something from that person. I just don't have that person to tell me if it's true, or, if that's the case or not. And so in that situation, we will test people that we haven't established a genetic cause in the family, but they fit that family history that makes us suspicious. And so in that situation, yeah.
This should be the frequency.
So typically people are told like every 3 to 5 years to at least go back and ask the healthcare professional to say, has anything else been discovered? Anything I haven't been tested for that I should be? Now, she should never go back and get tested for BRCA1 and 2 again. That's been done, right? And the only exception to that is also our technology has advanced over the years. But I would say in the last, this is 2025, I would say at least in the last 15 or so years, that technology hasn't changed. So if you were tested for BRCA2 and BRCA1 10 years ago, you're not going to gain anything you've done now. But if you got it done maybe back in 99 or something, then yeah, there may be, our technology is a little better at finding some of those variants. It may be worth doing it again. Mm-hmm.
That's true. Arnett is mentioning the fact that funding has been cut for cancer research. And I remember once Benita Pino, who was working with the ACS at the time, and she wondered about that question several years ago. And so what happens is when the funding has been cut, and that means research stops, when it's been delayed. It also means that people lose their jobs, because oftentimes these are grant funded positions, sometimes they are regular positions. And when that happens, that impacts the economy in many ways, because many of these people have families. So that impacts them that way. And it also, it just doesn't help the advancement of cancer, because as I mentioned earlier, the data is showing that cancer, many different types, so there are over 200 different cancers, but many different types of cancer, breast, colon, pancreas, prostate, are occurring in much earlier ages. So if the funding is cut for research to look at why this is happening, that impacts us a lot. And I might mention too that the American Cancer Society has a study on Black women. And I have literature on that, but for the sake of time, I just mentioned, please consider going over and picking up some cards on that, because they're studying women over a long period of time to see why we are developing cancer. So I would encourage you to pick up one of the cards over there. I am an ambassador for Voices of Black Women.
I just want to make just one last quick point is that, again, understanding we are in discovery mode. So we may do all the testing and we can't find anything, but I would have a really hard time saying that there's no genetic cause to cancer. Like I would not be able to see, because we don't know, there's literally 20,000 genes and we haven't figured them all out yet. So even in the situation where that testing has come back negative, there can still be recommendations for surveillance that are still slightly higher than the general population. And I'll say one quick guideline that we often say on the women's side is if someone in your family has developed breast cancer, that you start your screenings at least 10 years earlier than the age they were when they developed it. If you're 28, we'll just say, around 30. Now, 20 is really young to start doing mammograms, but should that conversation be had? Maybe can a baseline mammogram be done at 25, even if you don't maybe go back and do another one until 30, but like that would be a consideration of a recommendation that would be made. For men, because it does impact that risk for prostate cancer, it may be, most men maybe around 50 start doing screenings, maybe start around 40, or at least start having that conversation. So those are, so just to make the point that just because you can't find that genetic cause, it doesn't mean that it's not inherited. And there still might be, even if it's not genetic testing, there still might be other ways to still address the fact that that family history is there and that risk is there. And to your point about the studies, there are also similarly clinical studies where we can't identify a change, but there are people who are still looking for other genes and they might be very interested in your family and being involved and learning more about maybe other genes.
And Barbara's going to be around at the session ends, because we do have several other speakers, and because we're in a different time zone, I don't want them to get confused about when they are coming up. But I'd just like to give each of you 30 seconds to 1 minute to make some closing advice to the audience or even to yourself.
I do agree that early detection saves lives, and beating cancer is the team.
Okay, early detection saves lives, and beating cancer is a team effort.
I concur. Early detection, that's how I found my son was first diagnosed with me in the shower. And you have to know your body. See any changes, no matter how small, minute it may be, go to the doctor, get it checked out. I mean, to not know, it's just dangerous. I mean, that's what they're here for. I mean, get multiple opinions, whatever it takes, but go to the doctor.
Thank you. And that reminds me of, if we travel a lot, they tell you, if you see something, say something. So we know our bodies better than anyone. If there's something that's different, you want to consult and visit your medical team. And if you feel ignored or dismissed, there are others that you can go to. Give me a call, and I will help you find a referral. Okay. Let's give our ladies a good all right. And so now we are going to, now that we've had our intimate fireside chat, we're going to hear other survivor stories. And so we talked a lot about breast and ovarian cancer, the link between the two. I am pleased now to welcome Dr. Nancy Novak, who is in Austin, Texas. Dr. Novak is a 21-year stage 4, yes, ovarian cancer survivor. And she has a wonderful organization. She is the founder of called Nancy's List. And if you're on my breast cancer list, which you really should be, and shame on you if you're not, you will receive copies of Nancy's List. It is phenomenal, and it has a wealth of information. So, Nancy, are you ready to tell us about your journey and the wonderful work that you do with Nancy's List?
Hi, I'm Nancy Novak, and I am so pleased to be here with Thelma and her wonderful, wonderful family and friends. 21 years ago, I had a severe pain in my belly, in the right side of my belly, and I thought I had an appendicitis attack. So I went to an internist to examine me and immediately sent me off for a CAT scan, which I had no idea what that was. And what seemed to be an interminably long time, she called me in and said, "Do you want the good news or the bad news?" And I said, "I want the good news, of course." So she said, "You don't have appendicitis." And I said, "Yippee, hooray, hurrah, thank you very much, bye." She said, "No, no, no. Are you ready for the bad news?" I said, "No." She said, "You have stage 4 ovarian cancer, which has metastasized to your liver, which is 2 times its appropriate size, more like a small watermelon. And your right ovary is the size of a grapefruit," which I still find humorous that tumors are compared to fruits. So I said, which are now remarkable things. I said, "Oh, thank goodness it's not appendicitis." "And what's stage 5? So I was pretty naive then. So I was swept away to Stanford to meet, I was living in California. I was swept away to Stanford to meet this oncologist who would really save my life with his heart and his expertise. And when I entered Stanford's Cancer Center, I really couldn't breathe. That was the very moment that defined the rest of my life. My friends and my family soon arrived at my bedside, and they were all from all San Francisco and Southern California. That was nice. But true to the nature of a high-powered teaching hospital, every medical student, oncologists, the fellows, and seemingly every person in the Western world also arrived at my bedside to poke and probe. That was not so nice. Around 8:30 that evening, a man walked into my room, which was filled with my lovely loved ones and some shady characters who were sharpening their scalpels in one dark corner. And the man looked a bit like Santa Claus. And I asked a pretty crazy question, but I've been poked and probed all day by a bunch of strangers. So I said, "And who might you be?" And his response is, "I am your doctor." So, whoa, okay. And he told the scalpel people that Nancy was too sick for surgery. We're starting chemo immediately. Well, that was scary. And then he said, "Yours is a bleak diagnosis, and you have very challenging prognosis. I think I can help you. I am with you." And everyone in the room heard those words, and there was a big sigh and big tears. And those 4 words, "I am with you," became the most important words in my world and changed my life forevermore. And then he said something that still blows my mind. He said, "When your friends and your family go home and you think about today and feel overwhelmed, please call me. This is my home phone number." And guess what? I did call him at 2:30 a.m. He was as kind and caring in the middle of the night as he's always been throughout my cancer experience. He was real, he was authentic, he was always honest and available. And I wish everyone had the same trusting relationship with their oncologist as I was truly blessed to have with him. He brought meaning into the cancer journey and to my existence. He made me understand the healing process. And it was one thing, if he was so committed to my healing, I did everything he told me to do. I was too. And I trusted him implicitly. And this allowed me to open my heart to the amazing generosity of strangers. The wonderful, wonderful, compassionate, sensitive nurses in the infusion rooms. I called them the angels in my midst. To the patients who rooted for one another and who really cared. To my friends and loved ones who became the Nancy's A team. I never, ever felt alone. And opening my heart to the blessings and the prayers, that's what changed my life. That's what saved my life. I let it all come in. I began to understand and commit to the will to live, as well as comprehend the value that commitment and community has to manifesting courage and resilience. I fulfilled my purpose to bring light to others who had lost their hope. And this was a transformation. This was an opening and a truly different way of being. In my mind, opening my heart to the many acts of kindness and blessings saved my life. So I encourage you to encourage your courage. your compassion, your immense gratitude. I think it makes it work. And to have an oncologist who related to me with psychological mindedness was beyond my wildest dreams. It helped when he said, if you're on antidepressants, double them. And if you're not on them, get on them. And find yourself a solid psychologist, preferably one who's experienced cancer. This will be a rocky road. You need all the support in the world. When my sister asked him about my diet and my love of ice cream, suggesting that I needed to change my wicked ways, he said, I don't think this is the time to deprive Nancy of any pleasures. If every oncologist understood the importance of emotional healing, the world would be a better place. I'm a psychologist, and I really believe cancer is all about our emotions. I did a ton of aggressive chemos. I had a gazillion scary issues. I never did the standard protocol of debulking. After 2 years of treatments, I did a laparoscopy to remove my ovaries and tubes, and I've never had a recurrence in 21 years. I was blessed to meet Rachel Reman, who became my mentor and my friend, and she talked about the will to live. And I realized this was a very strong force in my healing process. She talks of opening to the possibility, and I adopted that belief as one of my core healing strengths. I learned about encouraging my courage, to own it, to live it. Telling my story brought meaning to its existence and contributed to my healing. I hope many people will share their stories with others. Cancer is trauma, and with overwhelming trauma may come a ton of gratitude and perhaps a touch of enlightenment. A touch. So my oncologist saved my body, and Rachel saved my soul. What happened while I was going through cancer is that I spent a ton of time in the infusion room, as many of you know about the infusion room. And I'm a clinical psychologist, so I ask a lot of questions. And one of the things that I love the most or appreciate the most about cancer is the immediate intimacy that comes when you talk to a cancer patient or cancer thriver or survivor or someone who's living with cancer. And I asked a bunch of questions. And I was struck that more people were scared of not having the money than they were scared of dying. And they would tell me the stories how they couldn't afford the medications, so they put food on the table instead and never told the doctor that they weren't taking the meds. There were ongoing stories, and I was very, very struck by this and very upset by this, that people in this country did not have the money and fear that they would not get treatment if they told their doctors the truth. One man said to me, I'm considering ending my life because I'm a burden to my family financially. And I made a vow that when I got through with this process, I was going to go find the money because I thought it was critical that these people could eliminate some of the stress and get the support for their healing and the family that they live with. And that was my goal. In 2006, 2 years into my treatment, I started Nancy's List. And that was conceived initially as just a list of financial resources. And I spent tons and tons of time looking for all the resources that would help people financially. And I'm still doing it, and I'm still adding. And even when COVID came in, I found all these resources that were available to people who were living with COVID, who had cancer, and how fearful we were about COVID. And this was really an important piece. And it's morphed, it morphed into a community call to action that I was living outside of San Francisco, and we adopted families in the community who were living with cancer. And we took our families to treatments. We watered their plants. We tutored their kids. And these were all just people in the community, mostly teenagers. And they brought food on Friday nights, and they took this on. And we had senior citizens meeting up with little kids from the preschools to make cards for all the kids who were going through cancer. We decorated the wards at UCSF for the children with every holiday. We brought gifts and we did all kinds of things. It was a great community action. And then it changed again, keeps changing. And at one point it was when I had 2 children coming into my practice who were upset because one of their parents was dying from cancer, and one child feared she'd be sent back to Mexico as an orphan. Again, she had been adopted by this family and started a club for just kids, an adventure club. So every weekend, kids who were living with cancer had someplace wonderful to go to. And that was just well respected and well financed by the community. And now I've moved from California to Texas, and I have no reciprocity as a clinical psychologist. So what I decided is that I needed a bigger audience, and I wanted a bigger audience. I don't know if I needed it, but I wanted to find resources that would strengthen the healing process and hopefully eliminate some of the stress and anxiety. And I really got into this thing, and there are so many resources for the breast cancer community as well as the ovarian cancer community on my website. And it's a website, nancyslist.org. And it goes into a lot of financial support. It's huge. And I can't take a whole lot of time, but I'm very proud of it. It talks about different diagnoses and the resources that are available to each one of those diagnoses. And it offers help about camps for kids that are free to kids who are living with cancer, to retreats for adults who are living with cancer, all of which are free. It has many, many resources for different populations and many, many resources for the African American community. It talks about all of this. So I welcome you, www.nancyslist.org. And I am so grateful to Thelma. I met her at Smith Center when I was doing a workshop there about financial support for our community. And we've been buddies ever since, and it is a treat to be here today for me, and I'm just honored by her presence and her generosity and grace. Thank you so much.
Said that about 2,800 men will be diagnosed with breast cancer, and of that, approximately 510 will die. In women, it's approximately 316,950 will be diagnosed. And in terms of death, 42,170. So as we can see, there is a big difference, and breast cancer in men is rare, but it does happen. We have Alan Herbert, who will tell us about his experience. He is a 2-time breast cancer survivor and a space cancer research advocate. Thank you, Alan, for being with us and for continuously sharing your work through the Thelma D. Jones Breast Cancer Fund and a lot of other organizations.
First of all, I'd like to thank Thelma. She invited me to speak a year ago through a friend of mine, Ken Harvey. And that was the first time anybody had ever invited me to speak about space cancer. And so when I finish speaking, I want to talk about what has even happened during that year. I'm going to talk to you about what is called Healing Beyond Earth, a space enthusiast cancer journey and the promise of space cancer research. You know, my life has been focused on space and the the promise of a new way of living. I was always looking for a world almost like Star Trek, multicultural, everything was done. There was no poverty, no diseases. And that was my STEM program back in the 70s and the 80s, because at that time there wasn't a lot of STEM. And shows like Lost in Space, Space 1999. But that was very important for a young Black kid living in Berkeley, California, that really single mom, didn't really have a lot of mentors looking at engineering. And so from that, I subsequently went to USC. I wanted to be an astronaut, okay, like many of us. And I earned my degree in aerospace engineering with the dream of becoming an astronaut. That didn't happen. I'm still here on Earth, didn't make it, but I'm still feel that you can make an impact. Though that dream didn't come to fruition, my passion from space remained. As years went on, I worked in the technology sector. I worked on technology sales and later married and have 3 children. We lived in the Washington, D.C. area, which I really enjoyed. But again, even though I was in that sector, the technology, software, internet world, space was really still there inside of me. I later divorced and I became a single dad, raising I had 3 kids, but I raised my 2 sons in Virginia, worked in real estate and marketing, basically. But then in 2007, the unpredictability of life, a routine conference attendance led to a life-changing diagnosis. I felt a lump on my chest and I'm like, what's going on here? And I went to the doctor and they did a biopsy and they said it's breast cancer. And I said, wait a minute, I'm a man, that's not possible. We're not supposed to have breast cancer. And of course we can. So it took me through a complex journey. The subsequent years are marked by significant medical and personal battles. I underwent surgery, numerous chemotherapy sessions, and a continuous medication regimen. In 2014, I had a challenging custody battle and learned that cancer had metastasized to my lungs and bones and necessitating further chemotherapy. I had been dealing with cancer for 18 years. Subsequently, my cancer was phase 2. Now I'm in stage 4 breast cancer. But, I didn't let it stop me. I just kept moving forward with my dreams. My life became positive. I got married again. And I embraced my new family life and secured a dream job in what they call the new space industry. I made history by sending the first oven into space, baking the first cookie, sending the first palm tree in space. I worked for a company that sent experiments up to the space station, sent 18 experiments for in the UAE, Dubai, the first astronaut from that area. And I opened the first space agriculture firm in the UAE, which they assisted me with. So I was doing so much there that I moved with my wife to Abu Dhabi, Dubai, where I helped establish my company's regional office. I was particularly struck by a level of care provided there. The healthcare there was really good. It was really great. I had a great oncologist. He gave me his home phone number. I mean, it was really great. There was great in America too, but they were a little bit more personal. So I continued treatments and checkups and everything there. But during that time, I kept my battle private. I never talked about it. Man with breast cancer or cancer in general, I just didn't talk about it at all. However, while I was there, I learned the importance of how space can be used to make an impact on Earth. But in 2022, while I was there, my condition worsened and I faced an additional challenge of a job loss while overseas. This was a difficult time emotionally and financially for my wife and I, but we made it through. With our children, mostly independent, my children are all over 25 now. But that time I just had one in college. So we moved back to the US, and to be closer to my family, I settled in Las Vegas. and which helped with accessibility family, which was good. There, I promised a new chapter within immunotherapy. I had somebody introduced me to Dr. Preek, and he was just one of the best oncologists. He was really, really good to me. A matter of fact, he's done a story about me. We did an interview together locally. I mean, he was really good. He is really good because I'm still dealing with it. But then also I hear about genetic testing. So he encouraged me. So I did genetic testing. It showed that both my children, my sons are susceptible to prostate cancer because of my West African background. They still didn't know where the breast cancer came from. They have no idea where that came from. But it really, I start talking to my son about prostate cancer. I have a daughter, and I talk to her, make sure that she gets tested. But I would recommend everybody, again, as we were talking earlier, to get genetic testing. But that journey, I said, you know what? I'm going to start talking about it. And with my love, I put my love of space and cancer research together, learned that NASA and a lot of private companies were doing research up in space. So I became the champion of the cause of advanced cancer research in microgravity environments. And some innovative drugs came through through some of the companies. So I just started speaking all around, and thank God for Thelma. That was one of the first places I spoke about it. But some of the things that have happened in space, people didn't even know about. My ecologists didn't even know about it. They said that some cancer cells in space age faster, which speeds up drug testing for cancer treatments. And it helps develop cancer treatments by studying how cancer grows quickly in space. Some cancers slow down in space, so they're trying to find that turn-off switch in microgravity. What makes it slow down, which is great. And then there's discoveries of some promising drugs in space through Merck. One drug, representative, I can't pronounce it all the time, right? Shows a promise as cancer treatment. This opens other impacts. Keytruda, many of you heard of Keytruda. They did some testing in space several years ago. They showed that in microgravity, that they can look at personalized cancer treatments, and that it makes treatment work better in space. Of course, everybody with cancer can't go into space, so they send these certain stem cells up of our bodies, and they check it up in space. It's really, really cool. And so there was a lot going on, even in terms of exercise. They found that the exercise that the astronauts do, that they can do here on Earth, that can help people with cancer treatment. So much is going on. So now I'm very involved in being an advocate for cancer, but also adding that space part to it. And what it does is, when I speak at certain places, especially in the space world, after I speak, people come up to me and say, hey, I need to get tested, or they look and see ways that they can find out what's going on in their families. And with cancer, it was really eye-opening. So I always tell everybody at the end when I speak, I urge them to stay proactive about their health by getting screened and tested regularly, which some people are, just because what I'm saying, in a realm where a lot of people don't think about that. In the space world, we're all trying to live forever and be very healthy like astronauts, but things happen. And then I tell them to approach their cancer diagnosis with the same curiosity and rigor as when we go into space, there's a lot of people involved and a lot of details have to be done. So I tell them, really study what's going on with your cancer and be very proactive with it with your oncologist. And then I advocate for increased resources and activities in space cancer research to drive progress. And so, right now, since the year since I spoke before, I do consulting. This is outside of cancer, but space. I work with an organization in South Africa right now, and they want me to do speaking there. I've been invited to speak in Kenya about space cancer treatment because they see a lot of men don't want to talk about prostate cancer. And space opens up that door. I'm involved with an organization, an international organization called AstroAid, which looks at using technology from space to impact healthcare here on Earth. So I speak to people from all over the world about space cancer research. Now, in Dubai, they're building a space medicine center. So I recently started talking to them about being involved, getting cancer research more involved in that, what they're doing. And then I'm writing. I've always been a writer, but now I'm writing on sci-fi books dealing with cancer and for young people and things like that. So what I'm finding is that I'm getting a lot of traction from overseas, which is great. And because I think, you know, what you guys are doing, what Thelma's doing, this thing is international right now. And people really need to hear and see what is going on. And so I'd like to thank everybody, Thelma, for giving me this opportunity. I believe I'm a very optimistic futurist. And I believe one day that there will be orbital cancer research centers on the moon and Mars, because one of the things that's happened is we go out into space, people think that you can just go out and do that. But no, we're hit with radiation, all kinds of different things. So we are susceptible, even more so, for cancer when we go out into space, and they need to do research now. But the great thing about it is that that research can be impacted for us here on Earth. And that's what I really try to get people to focus on, that it's just not going out there and just, you know, going on the moon or going to the space station. There's a lot of research going on that has already impacted Earth. So thank you all so much. I'll do whatever I can to help Thelma, but I hope that whatever we do can make her even more international. So thank you so much.
At the World Bank Group, I am sure there is a platform there just waiting for me to tap to help you with your efforts. And thank you again so much for always heeding my call. Even when every time you've spoken, this may be the third or fourth time, we've had technology issues. So please don't take it personal, and thanks for coming back this time. And now we are going to move to a different type of breast cancer. So we've heard about a lot of subtypes from triple negative, triple positive, triple negative, but we're going to and we will hear a short video from Bria Hickson, who is a Thelma Jones Breast Cancer Fund ambassador and also an inflammatory breast cancer survivor and advocate. Are we ready to roll with the video? And while LaShawna is doing that video, I want to certainly recognize our table. Yes, we have Dr. Danielle Smith, who is with the Ralph Lauren Center for Cancer Prevention, who is working on an oral study, that is, and we've also shared information. She's spoken at our breast cancer support group. I also have, if she doesn't have enough over there, I have some of her flyers at my table as well. We also want to recognize Michelle Hawkins, who is the community outreach liaison for the Department of Disability Services. And we certainly want to be, yes, there's this. Certainly want to be in touch with you, because just as every December, our support group meeting is focused on the family, our family stories and children with breast cancer survivors, family history, I should say. every November, we focus on breast cancer survivors with disabilities and the disabilities community as a whole. So we definitely want to check in on that.
Okay.
Greetings, I'm Bria Hickson, and today I want to share a deeply personal journey that not only has transformed my life, but also highlighted an important issue surrounding inflammatory breast cancer. I'd also like to thank Thelma D. Jones Breast Cancer Fund for continuously allowing me to advocate for young women. At 29 years old, I was diagnosed with inflammatory breast cancer in September of 2020, just a few months after welcoming my son into the world. Imagine the joy and anticipation of pregnancy mixed with the shock and uncertainty of a cancer diagnosis. It was an overwhelming experience, and I'm here to shed light on my story and the alarming statistics that surround this rare form of cancer. Inflammatory breast cancer, or IBC, is a rare and aggressive form of breast cancer. It accounts for only about 1 to 5% of all breast cancer cases in the United States. Unlike most breast cancers, with a lump. Instead, it shows up as redness, swelling, and skin thickening on the breast, symptoms that can appear quickly and often resemble an infection. IBC progresses fast, which is why it's usually diagnosed at stage 3 or stage 4. This disease affects younger women, especially those under 50 years old. And Black women are diagnosed with IBC more frequently, often at more advanced stages than our counterparts. Now let's talk survival rates. The 5-year survival rate for inflammatory breast cancer varies depending on the stage at diagnosis. For stage 3, the survival rate ranges from 55 to 70%. For stage 4, when the cancer has spread to other parts of the body, the rate drops to about 20 to 30%. Treatment usually starts with chemotherapy, followed by surgery, typically a mastectomy, and then radiation therapy. If the cancer is hormone receptor positive, then targeted treatments may also be used. While IBC is rare, its aggressive nature makes early detection and awareness absolutely critical. This rare disease is often difficult to diagnose early because its symptoms can be mistaken for other conditions. In my case, I began noticing unusual changes in my breast a few months into my pregnancy. These included swelling, redness, and a rapid change in the texture of my skin, also known as peau d'orange. I mentioned the symptoms to my physician at the time, and she referred me to a radiologist. I was unable to get a mammogram as they are not always the best effective method for identifying breast cancer during pregnancy. I was offered an ultrasound instead. The radiologist could see changes to my breast externally, but internally showed nothing on the screens. After my physician received the results, I was given antibiotics to take for 40 days, as my doctor believed I was experiencing mastitis, which is an inflammation of the breast tissue that can lead to an infection. Symptoms might seem minor at first, especially during pregnancy, but they were the early warning signs of something much more serious. Awareness of these signs is crucial, especially for pregnant women and new mothers who might overlook them while adjusting to motherhood. At my son's well baby visit weeks later, I mentioned to my lactation consultant that he wouldn't nurse on the left side of my breast. I was dismissed. At a follow-up appointment weeks later, I mentioned this again to a different lactation consultant, and she knew something was wrong immediately after examining my breast. She referred me to a breast clinic for further examination, and after undergoing several tests and scans, I was diagnosed with stage 4 inflammatory breast cancer. I want to emphasize the importance of early detection and continuous dialogue around women's health issues, especially during pregnancy. My journey has taught me the value of advocacy and awareness. If you notice sudden changes in your breast, especially redness, swelling, or warmth, talk to your doctor right away. Together, we can empower ourselves and those around us to recognize the signs, share our stories, and stand united in the fight against inflammatory breast cancer. I hope my experience inspires you to prioritize your health and awareness. It was an honor to speak with you all today. Thank you.
Thank you so much, Leah. I think she might be listening in. Or
She is. She is here. She's listening.
I know you are on. And thank you for sharing information about inflammatory breast cancer, or IBC, which is still a breast cancer that a lot of knowledge is not shared. We will, as I mentioned earlier, all of our presentations will be sent out on my distribution list as well as Facebook and YouTube. So you will get to not only hear them again, but have the opportunity to share this with your network. So our last speech or talk is on the message of advocacy, something that we've heard and referred to several times today. We have with us all the way from the Big D is Sylvia Powers from Dallas, Texas. And Sylvia is the project coordinator for the National Consortium of Breast Center. This is Sylvia's third time speaking with the Thelma D. Jones Breast Cancer Fund. So welcome, Sylvia, and we look forward to hearing from you and just reminding you that you stand between lunch.
Okay, I don't like to be in between food because I love to eat, and I just hate that I'm not there with you so I can enjoy the fabulous meal that I know you're about to partake in. But I'm grateful that I've been able to partake in the spiritual meal and the informational meal that you have prepared so graciously. That has started off with Dr. Natalie Johnson, who is also a trustee for the National Consortium of Breast Centers. She is amazing, amazing surgeon, speaker. A lot of people don't know she started out with the desire to be in the ballet with the Harlem School of Dance, but I'm grateful that she did choose another alternative because she's been a blessing as she has shared information and specifically been able to encourage those in the community that are like yourself and that are like me as well, Thelma, that are in the trenches dealing with breast cancer. We've talked about so many things and there have been doctors and the research information and the survivor testimonies that have gone forth are absolutely wonderful, but they actually do have one common thread is advocacy, because advocacy is just the process of helping to disseminate the information. Advocacy comes in the form of being able to bring about awareness. And there's no doubt that the speakers, all of them, have brought about awareness. I've learned things today that I did not know in reference to the link between breast and ovarian cancer and prostate and pancreatic cancer. I knew, of course, the link with breast and ovarian cancer, but I did not know about the link with prostate and pancreatic cancer. So knowledge is power. If we know better, we can do better. And that's one of the key components of advocacy is that we want to help people in the community know better. Because, of course, when we look at the disparity, when we look at the high mortality rate of African American women, and when we look at the mortality rate of Hispanic women, when we look at the mortality rate for those that don't have access to health care, we want them to know better. And we want to find ways like the Nancy's list that will help them do better. Because a lot of times the reason people don't do different things is because they don't have access. They don't have the resources. As one person was speaking and shared that there were patients that were eating and not taking their medication because they did have to make that choice. we as advocates want to make sure we do everything that we can to make sure that the community does not have to make that choice. We try to get that information out. I was excited when I heard about Nancy's list, but there's so many other resources out there. One of the things that we constantly hear is that people may not get mammograms because they can't afford them. But now, in today's society, there are so many resources out there. We want to make sure that the community is aware of those resources. And that is one of the key components of advocacy, is actually the awareness. But also there's the advocacy as far as policy changing, as far as you're in Washington, D.C., and I'm sure, especially this year, we've seen a lot of changes. But as things change, there are also inroads. As one door closes, another one opens. So knowing which doors are open, which doors that we still have access to, which doors have just changed the way they swing, which doors may still be open, but not as widely as they were open before, so that we can help patients get the best care, best service, get the most access that they can have. And that is the other thing, is supporting the patient, is being able to make sure that cancer survivors have access to meals when they're going through treatment. They have access to transportation. And over the last 12 months, I've worked here in Dallas in getting transportation for cancer patients. And that was not something that I realized was a great barrier. I found out there were people not just missing treatment, but who were missing surgery because they did not have transportation to get to the surgery. So making sure that they have access to surgery. And then the other strong component is making sure that they have access to funding for rental assistance, for utilities, for groceries, those things that are essential while they're going through their journey. As advocates, that's one of the things that we stay in the trenches. We keep our nose to the ground because we want to know every resource that is out there that can help us when it comes to getting information to patients, working with navigators, so that we can increase and change the outcome. I think everybody that is on this call, everybody that is in the room, that's our greatest challenge. That's the one thing that, from the physician to the advocate to the breast cancer survivors that are sharing their story, we want to see a change. When I started 30 years ago working with breast cancer, one of the factors was that African American women had a higher mortality rate than any other ethnic group. Today, 30 years later, that fact is still true. So we want to make sure that we do everything that is possible to change those statistics. And that's what advocacy is about. We all have one voice, but as we put those voices together, it becomes a resounding, a voice to be reckoned with. So whether you are an advocate like Thelma and myself, and you're in the trenches and you're working with survivors, or you're just somebody that is sharing your story, every story that was shared today was different, but every story was powerful. Every story was necessary. So no matter, I have a friend and she was stage 1 and didn't have to have a chemotherapy and just a few rounds of radiation. And she told me, she says, when I hear about some of the traumatic things that people go through when they have breast cancer, I felt like I really hadn't been through it. But I let her know that her story still counted. And she found herself sharing and being able to encourage some of her coworkers. She was even able to encourage a coworker who was afraid to get a mammogram. So we have to realize that sharing our stories and sharing our voice is important. And that's the only way that we'll be able to change the statistics. I think there were a couple things that were stated that were really important. One of the survivors said that breast cancer is a team effort. It takes all of us. It takes every one of us. We can do different things, just like Thelma organized this event to deal with breast and ovarian cancer. There's so many different things. We can lead campaigns. As advocates, we become a change agent. And the last thing in closing that I want to share is what was shared by Nancy when she said the oncologist said, I am here for you. As advocates, every single day when we get up, that's the one thing that we want to say to breast cancer survivors. I am here for you. Thelma has said it. She's echoed it. She serves as a co-chair on the National Consortium of Breast Centers Advocacy Committee. She says it as she does her monthly meetings for breast cancer survivors. She says it as she works in the community. That is the one thing I want to leave with you. We all are advocates. We all have that opportunity. And every day we have a chance to tell somebody dealing with breast cancer, I'm here for you. I also, as I close, I want to encourage you to go to breastcancer.org. We are having a virtual conference for those that are in the medical field and still need CME credits. This is a wonderful opportunity to get the information that was at our conference in Las Vegas. So please check out the information. And if you would like to reach out to me personally, you can reach me at sylvia@breastcare.org. And I would love to have you participate in our advocacy efforts. Thank you so much for this time.
So much, Lindsay. That was a powerful note to end on. We started wanting to know about the connection or the link between breast and ovarian cancer. And with the wonderful list of clinical speakers from including Dr. Johnson, Dr. Bavarian, Dr. Newton, and Ms. Harrison, we certainly got that. And then we moved from our clinical side to our fireside chat with our two ladies, lovely ladies, Karen Hargrave and Annette Retire, to hear about their experience. And from there, we heard wonderful survivor stories. Hearing their stories help to make sure that they don't become our story. And from there, and under that, we heard from Dr. Nancy Novak, Alan Herbert, and Julia Hickson. And then finally, Sylvia closed out. I think when he said, when we know better, we can do better. And that what everyone said was a key component in terms of understanding advocacy. And there's many ways that we can advocate. Please consider how you can do it even greater. And with that, I just want to thank again St. Augustine's Episcopal Church for being a great collaborator in this effort. Let's give them a big hand. Our Pastor Reverend Kara Rock here, who did the opening, and also we want to thank Burl Delaney, who is in the rear. Burl. And of course, our shameless promotion, if ever you'd like to host an event, you've been at the lovely space, so you don't have to do a site visit. You just want to email us and let us know when you're having it and how many, and any other type of logistics. I strongly recommend the place, okay? And of course, again, just to remind everyone to please stop over to our vendors. They've been very patient. To apologize to everyone again for our technical issues, but it is what it is. But we had great people, LaShawna Thomas Walker, who helped to shepherd us through this, and Sergio Jimenez. And last, of course, I want to recognize Anthea Peters, who is an ambassador with the Thelma Jones Breast Cancer Fund, and to give yourselves a round of applause. that he slept through the storm, but woke up with joy in the morning. I commend you. So now we can go down and have lots of food. And also, if anyone now wants to visit the Thurgood Marshall Gallery, we are available to that. Thank you, Anthony. She pointed to the gift bag, so we'll give you a gift bag as you're going down, and we'll do raffle and door prizes at the luncheon. So if you leave, you won't be eligible because you must be present. Okay? So let me, I'll get, my son Jamal will help you.